Yes, sir.
This is
Posterior column.
ischium.
Yes, sir.
That is posterior column.
Yes,
And
sir.
of course, there is the classification, middle column, isolated acetabular fractures,
Yes, sir.
T-type, T-type fractures, classification. Orthopedic fractures is an important chapter for
Yes.
theory. Recently, one pelvic fracture symposium has last Friday, there was a symposium on pelvic fractures. And cadaveric workshop was done in Gandhi Hospital, actually.
Sir.
They have allotted about 4 cases, 4 bodies for the people to operate on with hands-on experience. And senior surgeons have come from elsewhere. They have done, they have demonstrated all the exposures,
Sir.
anterior column fractures. Seniors, have you read pelvic fractures? Still 4 months time is it? Any idea about pelvic fractures? What are all the approaches? No idea. Okay, go ahead.
I done implant removal, sir. 65-year-old male with closed trimalleolar fracture of left ankle. These are the CT films.
అంటే ఇంకేం లేదు.
Yes, sir.
Don't want to speak anything else other than that. You have to classify fracture, any fracture what you have encountered, you should try to put it into classification. Otherwise, doing a technical job is a
Yes, sir.
is a technical job, not understanding what is happening there. Put the X-ray.
Yes.
So posted malus also is there.
Yes.
Let him read.
Six.
Describe the fracture.
This is a trimalleolar fracture, sir. It occurred due to supination and external rotation. In Log Hansen classification, it is type 4, sir, SCR. Supination, external rotation. 2.
What are the components here?
Lateral malleoli, medial malleoli, and posterior malleoli.
Malleolus is singular.
Malleolus.
Malleoli is plural.
Malleolus.
Many people are of the opinion malleoli is a
Singular.
People call it, even in the isolated malleolus fracture, people are calling malleoli, lateral malleoli. Malleoli is plural.
Yes.
Okay. How did you say it is supination external rotation?
Sir?
How did you say it is a supination external rotation?
Patient's history, sir. And
History will give.
and
Most of the times, patient may not be able to say whether it has gone into supination or pronation.
yes.
Valgus or varus. They don't remember how it has happened.
By looking at the
Going by
injury
the
pattern. Yes.
fracture morphology, you
Yes,
have
sir.
to decide which type of injury. So how do you describe that?
First, the deltoid ligament, and then the lateral malleolus, and then
Will you see the ligament here?
no, sir.
Describe the X-ray. Describe the X-ray.
Read, sir, read the X-ray.
What
Three
is the type
fractures
of
are
the medial malleolus fracture? What is the lateral
Displaced,
malleolus
sir.
fracture? And how is the posterior malleolus? What are all the components here? That's all, only fractures. Nothing else. Nothing else other than the fractures.
Displacement is there.
Fracture is displaced.
Yes.
How is the joint congruity?
Sir?
How is the joint congruity?
It's not good, sir.
Huh?
Axial compression law.
Articular compression.
Axial.
Huh?
Axial.
Axial, it's a vertical compression
Yes.
fracture. Do you mean?
Yes.
Huh?
Talus subluxated on this.
Then why do you call it as vertical compression? Vertical compression fractures are different. They are called pylon.
Okay.
Grossly comminuted articular fractures. Here the plafond appears to be reasonably good. There is a dislocation of ankle.
Yes.
The components here are the transverse fracture of the medial malleolus an oblique fracture of the lateral malleolus above the joint line, and then both the posterior malleolus as well as the fibula along with its tibiofibular ligament. Posterior tibiofibular ligament complex.
Yes.
There is the intraosseous ligament.
Intraosseous.
The posterior complex, which includes the posterior malleolus, the tibiofibular syndesmotic posterior ligament, and also the lateral malleolus. That is a single component, as you see here. See,
Yes.
this is the medial malleolus, posterior, that is the lateral malleolus, along with its attachment of the posterior inferior tibiofibular
Ligament.
syndesmotic ligament.
Yes.
So this is a single unit, and because it has been, talus has pushed this whole complex posteriorly,
Yes.
there is a posterior subluxation. It's not subluxation actually, it's a dislocation. There is no contact between the distal articular surface of the tibia and the talar
Talus.
dome. It's almost like a dislocation.
Yes. Talar shifts.
Okay, there is a significant lateral talar shift.
Yes.
Is a trimalleolar fracture with posterior. Is a typical supination external injury. The full component, there are so many, depending on the failure, starting from the deltoid ligament to the medial malleolus. The violence, if it stops in between, somewhere between the starting of the event to the end point, there are different combination of injuries.
Yes.
Here it is a full complement of supination external rotation injury with both malleoli, posterior malleolus and posterior subluxation or dislocation of the
Talus.
ankle. That is how you can say it's a supination external rotation injury.
Yes.
Simply putting this X-ray and going to the post-op X-ray. In between CT, and you have not described anything about CT. It is just not a ritual to present. You have to enlighten what is the fracture, what is the plan of management before you put the post-op X-ray. That is the purpose why you are standing here and presenting, not simply blurting out whatever you have presented there. Okay.
No, in supination external rotation injury, which fracture occurs first? The lateral malleolus or the medial malleolus or the subluxation?
Lateral.
or the posterior malleolus? Which comes first?
Laterals. Lateral malleolus.
Lateral malleolus comes.
Next posterior.
No, it is the medial one
Medial
that
and
fails
then
first,
posteriors.
not the lateral. After this fracture has gone transverse fracture, then if the violence stops here, it will not involve the lateral malleolus. If the violence keeps continuing, then the thrust of the talus will be put on the lateral malleolus and it makes a oblique fracture of the lateral malleolus.
First
It is the medial side that fails first.
Okay.
If it is the lateral one that fails first, then there will be a transverse fracture of the lateral malleolus and an adduction type of fracture in the medial malleolus. That is a typical pattern of adduction and abduction.
Why
Okay.
posterior malleolus occurs? Supination external rotation injury. Why do you get a posterior malleolar fracture? It goes like a circle.
On. External rotation.
Yes. So where do you say the supination? Where do you say it's external rotation? There is two components.
First.
One is supination, one is external rotation. Where is supination occurring? Where is external rotation occurring?
Until like at what point?
You didn't got the point. I don't know.
Let us stop. There are so many X-rays. So you have to read everything before presenting this case.
Yes.
You should have read the ankle fractures and then try to understand what is this fracture.
The sole of the foot faces medial.
Okay, next.
Itla aitadi, sir.
Goes externally. The talus moves external rotation and it comes back.
Yes.
Because of the strong delta ligament. Yeah, go ahead, sir. Then it goes to the posterior malleolus.
So how big is that? Does it require a CT here? And the X-rays are so clear. Does it require a CT scan?
Yes, sir.
Why? Does it give any additional information other than the X-ray? Then only we are justified in asking for a CT scan. Of course, it gives in great detail.
In Lange-Hansen classification,
As a general principle, all intra-articular fractures
yes,
require a CT study, provided it is required. It's not required in all cases. That is much more important in pylon fractures.
Okay.
Okay, otherwise called as tibial plafond fractures.
Yes.
Here it is not essential because you find three major fragments:
Yes.
medial, lateral malleolus, posterior malleolus, along with the fibula. It's not essential here.
Pre-ops. Pre-op. Post-op.
Here it is fairly a big fragment. It automatically sits into its fracture bed, and anatomic congruity can be achieved even under the C-arm. Okay, here it is not essential to have a CT. If there is a significant comminution, then it is indicated. Okay. Post-op.
So we have done open reduction internal fixation with plating for lateral malleolus and posterior malleolus, and malleolar screw for medial malleolus.
Which is fixed first, medial malleolus?
Posterior. Sir. Yes.
First to posterior. You are
Yes.
there in the case?
Yes.
So you are gone with the first to
Yeah.
posterior.
After the posterior.
First we have gone with the posterior malleolus. Second one?
Second, we did the lateral, sir. Lateral malleolus.
So then lastly,
Medial malleolus with malleolar screws.
Who has attended this case in the casualty?
In casualty, Vishal. Sir.
Where is he? What did you do in casualty?
First you take the distal pulses, sir.
Mike. So do you expect a vascular injury here? Why do you
No,
look
sir.
at the X-ray?
No, sir.
And do you expect a vascular injury in this case?
No,
Very
sir.
unlikely.
Yes, sir.
Of course, you have to look for
Yeah.
distal vascular status in any fracture, however simple it may be.
Yes, sir.
What is expected in casualty after taking an X-ray? There is a dislocated ankle here.
Yes, sir.
You have to
Try to
reduce it
reduce.
immediately. It's very easy to reduce.
Yes, sir.
So that the tension on the soft tissues is reduced, the edema subsides very fast. If it is left like that, the edema keeps on increasing.
Yes, sir.
Soft tissue trauma will be increased. Immediately should reduce. Apart from reducing the edema and giving comfort to the patient, the articular cartilage is nourished by the synovial fluid. When there is a capsular tear, if it is there, the articular cartilage will not be nourished by the synovial fluid. So it is essential to reduce any dislocation immediately.
Yes, sir.
Dislocation is an emergency, not a fracture.
Yes, sir.
Fracture is a relative emergency. Dislocation is a real emergency. That is a basic principle.
Yes, sir.
Okay.
the sequence, what he says, first you have gone with the posterior malleolus. Second you gone with the fibula. Lateral. Next you have gone with the medial malleolus. Yes, sir? Do you accept the sequence?
First lateral malleolus, sir.
You have to study the fracture pattern in this C-arm after reducing the ankle, and then what is the approach that you undertake, because you have to fix both the bones, not only the medial malleolus, but you should address the posterior malleolus as well as the fibula as a single complex. What is the approach? This is very important in reading this X-ray and approaches. What was the approach? Who has assisted? Huh?
I assist.
You have what was the approach?
Posterior lateral approach.
Posterolateral.
Yes.
Can you address all the fractures with that?
Single incision, multiple access.
Huh?
Posterior
You know, can you address all the fractures with posterolateral approach?
So, not all the fractures, sir.
Then is only one incision is
Yeah.
given in this case?
No, 2 incisions were given, sir. But
Ah.
first incision was posterior lateral.
That is what you said. We can address all the fractures with posterolateral approach. It's not feasible.
Yes.
Okay.
So first one is posterior malleolus. Do you accept, sir?
So if you reduce anatomically, of course, every component is important. If you, yeah, you are right. Posterior malleolus is the one that has to be addressed first.
Yes.
Okay, then medial malleolus, and then the lateral malleolus. And this is not the right plate for lateral malleolus. This is a DCP as a 1/3 tubular plate. Looks
1/3
like
tubular.
1/3 tubular. There is a contoured plate is there, no? Not available. Okay.
Plates.
What is this? What is this?
Which?
What is this X-ray? What is this
This
C-arm
is
film?
C-arm mortis view, sir.
Huh?
Mortis view.
Mortis view. You have to describe all these things. Okay.
Gaps. Syndesmosis. Joints.
Here, one medial malleolar screw is not adequate probably, and probably another K-wire will give rotational stability better than a single malleolar screw. Okay.
Yes.
When do you mobilize the patient?
After 6 to 8 weeks.
Mobilize, not bear weight.
2 to 3 weeks తర్వాత
Huh?
ROM స్టార్ట్ చేపిస్తాం.
Do you put a posterior slab after?
Yes, sir.
Do you put a cast after suture removal?
No.
Not
Cast
required.
posterior slab is enough, sir.
Enough. Slab invariably breaks. But if it is a rigidly fixed fracture, you can start mobilizing after the edema subsides, maybe after
2
10
to
days to 2 weeks,
2 weeks.
so that the ankle joint stiffness is prevented.
Yes.
Okay.
So you should tell the reason why posterior first, why lateral, why medial, what is important for you?
బటర్ స్ప్లిటింగ్ తోని posterior ని ప్రెస్ చేసి పట్టుకున్నాక 70% రెడ్యూస్ అవుతుంది కదా.
Okay. Next.
So how do you maintain the ligamentous complex and height of, and normal height of the ankle joint?
నార్మల్
Fixing the fibula. Original knowledge to give the articular component.
14-year-old with closed middle third sharp junction fracture of left humerus. We had on CRF with TENS for left humerus.
Why fixing? 14 years boy. First X-ray. Is a reasonably good alignment. No angulation. Alignment is good. Why not conservative? He's still a boy, 14 year.
Yes, sir.
It's going to heal very nicely. Okay. It's not required here in this case.
Yes, sir.
A hanging cast will do, or a U-slab, or a Sarmiento brace. And it becomes sticky in 3 weeks. Okay. What is the entry point medially?
Just proximal to first we
Where did it enter?
just proximal to epicondyle, sir, humeral epicondyle.
It's going through the medial so-called cubital tunnel. How is the ulnar nerve? Did you expose it before passing?
No, sir.
You were there?
Yes, sir.
That is not the right entry point. Just proximal to the, from the metaphyseal region,
Yes, sir.
not in the end. In the APV it appears it has gone through the the cubital tunnel. In the lateral view, which is the one medially going? Can you identify the one which is medial in the AP view? Can you identify it in the lateral view? Is it possible or not? Huh?
It's possible, sir.
Whichever is more distal in the AP view and whichever is more distal in the lateral view is the one, that is lateral one is the more distal in the AP view. Looks like that. In the lateral view it's clearly seen there is a difference in the distal tip. Okay. Did you look at the
Yes, sir.
neurological
Yes,
Status
Yes, sir.
post-operatively
Yes, sir.
normal?
Normal, sir.
Okay.
You have to talk about the entry point. It's also important.
Okay, next.
Talk about the entry point.
Entry point.
ఎక్కడ ఉంది?
ఆయన ఎక్స్పోజ్ చేయలేదు. ఆయన నష్ట చేసింది.
Trimal 74-year male with closed trimalleolar fracture dislocation of the right ankle. The mechanism of posterior dislocation. Subluxation. After reduction process. Initial X-ray was not taken.
ఇది at the time of injury na?
కాదు సార్, పోస్ట్ రిడక్షన్ ఇది
Where is the first X-ray?
పెట్టలేదు. ఇట్ వాజ్ అన్కెప్ట్ హియర్.
దొరకలేదా లేకపోతే మర్చిపోయాను? నువ్వు చూసావా first casual
ఎస్ సార్,
dislocation?
ఎస్ సార్, పోస్టర్ డిస్లొకేషన్.
Here there is still lateral subluxation.
ఎస్ సార్. The skin over the medial surface is not intact, sir. So we didn't open the medial
What do you mean by not intact?
abrasion,
Abrasion or a laceration?
abrasions, superficial abrasion. So we didn't open the medial malleolus for fixation. Instead, we passed KYs subcutaneously for medial malleolus and fibular plate fixation for the lateral malleolus. According to Log Hansen, this is supination and external rotation.
What type of fibular plate is contour plate?
On, sir.
Periodical contour.
On.
Very good, excellent.
61 years female with 6 weeks old intertrochanteric fracture of right femur, sir. Body Griffin's type 1, sir. We have done closure reduction internal fixation with the PFN, sir.
70 years old female with 3 weeks old unreduced anterior dislocation of right shoulder, sir. This is the X-ray when she presented to us. We have tried close reduction, but it wasn't possible. So we took CT, sir. Here we can see posterior superior defect of femoral head, and also we thought this fragment is interrupting the reduction as well. Hence we have in MRI they gave there is bony hillside. First episodes. Yes. No, sir. They gave. First episode. Yes, sir. Hill sacks.
There must have been a significantly depressed fracture.
Because what is the age of the patient?
70 years, sir.
So 70 years, what will be there at 70 years?
Osteoporosis. She underwent massages twice. Yes. In CT they gave us bony Bankart and a Hill-Sachs lesion, both are present, sir. And intra-op, this is the fragment, sir, that we have seen, Hill-Sachs lesion.
You have to tell what is the approach before describing the
We opened through deltopectoral approach. But as it was said in CT report, there was no bony Bankart lesion, sir. Since the fragment was... yes, sir. This is fragment, this is Hill-Sachs lesion, sir. But in CT they gave bony Bankart as well, sir. But intra... by external... Sir? Yes, sir.
close the defect using lesser tuberosity, or you put some infraspinatus muscle into it, or what did you do? How are you going to prevent the next dislocation?
Since the fragment was less than 1 centimeters, we have just reduced to it anatomical position and sutured with the ethibond, sir.
No, no, I'm talking about a hill sac defect. It's almost 1/4 of the humeral head. Have you seen that on the CT?
Yes.
Yeah. So it's almost 1/4.
There is a high chance of recurrence.
So what you have done for this? Because you can't approach this through deltopectoral. It's looking like a deltoid split approach.
Deltopectoral lungs.
Okay.
She is a female examinative work, so everything is lax. You can repair it in approach, nothing wrong. In people, it's a problem, especially for sports injuries. This is a big problem.
So the normal history of these are what happens with an anterior dislocation is with the osteoporosis in place and all that, it might have been an engaged dislocation for about 2 to 3 weeks. So what happens is the capsule all around it gets tethered, and the capsule goes and is inserted inside the joint. So that also prevents reduction. So when she has overgone massages over it, the capsule gets even more thickened. So even though you try to reduce, it will not reduce. Bony block is not a big block, but this engaged dislocation is preventing further reduction. So when you get it back into place, you have to release the almost the tethered capsule, anterior capsule.
Yes.
Almost you have to do a capsular release kind of a thing all anteriorly, and then relocate it back. And always when it's such a huge hill sac defect, you have to do some bony procedure. Probably at least soft tissue reconstruction, because she's 70, bony procedure, we're not expecting a high quality of shoulder function.
What is the Remplissage?
Remplissage procedure, Remplissage. Remplissage is a French word. Filling the defect. హెల్ప్ చేస్తాం సార్ ఎగ్జామ్ కనీసం చెప్తే చెవులో పడితే గుర్తా ఎగ్జామ్ గుర్తా 60 సార్లు చెవులో పడితే పాయింట్ ఒక మార్క్ అయినా వస్తుంది.
Once the
We are going to present this case today. If you are read about this so-called shoulder dislocation, hill sac lesion, what is the instability, what is the recurrence, how to address the hill sac lesion. Okay. Next.
then we have once the fragment was reattached, we were able to reduce the shoulder, sir, and then fixed with the 2 mm K wires.
What reattachments are we doing here? Which fragment?
This hill sac lesion, we could identify this fragment, sir, when we opened. So what we have done is we have resutured it to head of femur by ethibond.
When you're putting, put some arrows, black arrows, white arrows, so we can see what you want to demonstrate.
This was the bony fragment that we saw, sir,
Okay.
which was obstructing. We thought it is a part of a defect in the femur head, so we resutured it to the humerus head, sir, through ethibond.
So it had any attachment of the cuff or anything?
Yes, sir.
If you see, the defect is, the piece is almost 1/5 or even lesser than that. So what have we achieved?
We got reduction, so once we have attached it, at least we got
That's what
reduction.
I'm saying. If you release the anterior capsule, almost you will get the reduction. Okay? And
As Dr. JK has said, the fragment appears smaller than the defect. So it is osteoporosis that have made it a depressed component, depression of the osteoporotic bone. Yes. Supposing if this patient has come after 5 months or 6 months after the injury. What do you think? Is it possible in our scenario?
Shoulder.
If there is a reasonably good functional range of movements with less demand patients, simply leave it like that. You will
not be able to achieve anything better than leaving it alone. Or you may worsen it after surgery.
So this right side.
Yes.
So I have got one patient, first 84 she fell down from the staircase, tuck, fracture dislocated. After another 5 years, tuck, 89. So we treated both the cases like non-operative. So hand to mouth and to attending the natural cause, that's enough. So you can't demand for anything because she is already 72 osteoporotic. So everything is lax. So you have to strengthen the soft tissue also.
Especially in fracture dislocation.
Yes, fracture dislocation. That is very important.
Next.
Yes, very good point, sir. Very good case. The only cover is where is sir, antena. So no stabilization, no plaster, nothing. Universal shoulder and immobilizer.
Immobilizer shoulder immobilizer shoulder immobilizer.
That was without saying.
Yeah. You going saying yes sir. Please sir.
What's the plan when you will remove the
Rehabilitation. When do
We
you
have
put the cover?
3 weeks.
3 weeks sir.
Yeah.
Shoulder 3 weeks is muddy study.
What is the diameter of the KY?
2 mm, sir.
2.5.
2
Minimum or 3.
Three, ideally three.
And preferably threaded. Threaded KY. Otherwise it's likely to migrate.
Go with the fixation. Show the fixation. So it is totally reduced or still there is
Preferably
some
2 KYs. Because 1 KY still rotations can happen within the immobilization.
It will bend. It will bend.
Bend and break. So 2 KYs will give better rotational stability and chance of breakage can be minimized to some extent.
One table all is well.
yes.
Very good. Excellent. Next.
85 years old female with intertrochanteric fracture of right femur, sir. Boarding Griffin type 2. We have done close reduction, internal fixation, PFS.
Go back. What do you see the moment you see the pelvis extended?
Trabeculina. Osteoporotic.
Next
For
one.
trabeculina.
Huh?
Trabeculina.
Severe osteoporosis.
Yes.
Next one.
Trab-
Would you like to know something about Sin's index? Huh? Do you know what is Sin's index?
ఈ స్టేజ్ లో చెప్పాలి సిన్సియర్గా చెప్పదు ఎట్లా you have to use the word
What are the
sincere.
trabeculae seen here?
Pointer pointer అమ్మా
Primary.
As I first you describe that one. What is glaringly seen, most prominently seen? What is not seen, you are showing. What is seen, you must describe first. No.
Primary compressile trabeculae. Primary tensile. Secondary compressor trabeculae. What?
Secondary tensile.
It is secondary tensile. Watts triangle, Babcock's triangle.
What are the triangles?
Watts triangle,
No.
Babcock's triangle.
Where is the trabecular pattern continuing? Place it into the idiom. That is the line of weight bearing.
Yes.
That is where the condensation of the trabeculae takes place through the weight bearing zone.
it's called sourcing. Weight bearing part of the head of the femur in the osteoporotic. So they will have continuity. So in intracapsular fraction neck of femur, you have to putting into the quadrants.
Lead Sin's index.
That's why the
Huh?
trabecular pattern.
Might be a sharp notes.
Since index short
Sin's index is a sharp notes.
osteoporosis.
This is much more important in elderly people to know about the prognosis of your stability of fixation and chances of union of the fracture.
And there is one
Next.
more trabecular is greater trochanteric trabecular.
Was it a basal fracture or an intertrochanteric?
So basal fracture into
But it has extension till
Where it
greater
is
to.
intertrochanteric?
so there is avulsion of
Is it the one that we look at?
Cervicotrochanter. Yes.
You see in the other one. కనిపిస్తుందా? అదో పెద్ద భూతంలా కనిపిస్తుంది అక్కడ పెద్ద lesser trochanter. Is it going through the lesser trochanter? Then why did you call it as a intertrochanter? You are not focused on the X-ray. నువ్వే చేసావా? Did from A to J? మొహమాట పట్టు చెప్పు, చేసావు కదా? From incision to rotor? Then you did not read the first, the full length X-ray? Obviously not. See, it's very clearly, original fracture pattern is in the right X-ray, right sided X-ray. Lesser trochanter is completely intact. This cervicotrochanteric fracture. You said it's intertrochanteric. Okay. We are not making use of the clinical material to the full extent. It has become a ritual to operate.
The 60 years female with the intertrochanteric fracture of left femur. There's a close reduction internal fixation with PFNs.
Comments on the fixation.
There's a positive reduction.
Lateral column is intact.
Yes.
Okay. Medial column
The step is
stable.
there.
Stable or not? Is there any comminution?
No.
It is almost very well aligned. In fact, it is impacted. Impaction is a good thing for fracture healing, for stability. Then, what else will you look at? This is the whole purpose of this, putting all these X-ray for surgical audit. Otherwise, it's just a post-op. We are not planning anything out of the, it's only a technical job that we are doing. That's all. What is the position of the screws? What is the top of the nail? Are the screws placed well in position? What is the length of the proximal screw? What is the length of the distal screw? Distal, I mean the screws in the neck. What is DAD?
Tip apex
So many
distance
things
is
you have to read in the X-ray.
the distance is more.
Unnecessary wasting of time. And are you happy with the length of the screws? One is the distance from the subchondral bone to the tip of the screw.
Less. Distance.
Both are at the same level.
Yes.
Is it the right thing or is it different?
So big.
Derotation screw should be lesser than that of compression screw.
They are almost looking like
Same.
exactly in the same place. Okay.
Follow up this patient, okay? The reduction is negative, whatever happens, just follow up.
Yes.
All elderly. All 70s and 80s.
71-year-old female with intertrochanteric fracture of left femur, sir. They have done CRF with the PFN, sir.
All elderly people better go with the long PF. Why?
Less risk of failure, sir.
Quality of the bone is poor.
Yes, sir.
So with the quality of the bone, you have to regain the quality. How do you regain quality?
And high chances of stress rise at the
Yes,
bunda
stress
and
will affect.
peri-implant fracture.
Yes, high chance. This is already important. The quality of the bone is also important. Not 45, 70, both are not same. ఇప్పుడు ఎంత ఏజ్ ఎంత
71, sir.
మరి ఎట్లా దొరాలి పాయింట్ క్యాచ్ చేయాలి
55 years female with intertrochanteric fracture of left femur, sir. Boyd and Griffith classification type 3, sir. Sir, 4, sir. Yes, sir. We have done close reduction with internal fixation with long PFM, sir.
You use the washers?
Yes, sir. 2
washers, sir.
Yes.
A 56-year-old female with 1 month old closed bilateral calcaneum fracture of the foot with neck fracture of the left talus, sir. There are CT images, sir. Yes, sir. Fall from first floor, sir. There was also a T12 and L1 compression fracture, sir, which has been fixed outside, sir, with bilateral calcaneum. It is Lover's fracture, sir. No, sir. Everything is good, sir.
Is there plantar ecchymosis? Both those sides or only one side? No plantar ecchymosis.
No plantar ecchymosis, sir.
1 month old.
1 month old, sir.
When did you present here? 1 month.
1 month after, sir.
Both are closed.
Both are closed, sir.
Is the AVM changes are established or not established?
Not yet, sir.
No,
Not yet, sir.
ROI, what about ROI?
Spine X-ray, we have missed to put it, sir. We have missed to put it, sir.
Not ready.
Sir?
You have the X-ray.
Yes, sir.
The department.
Yes, sir.
Why you are not put that? It's equally important. What is done?
Left is worse because one, there is a talar neck fracture, there is no subtalar joint, it's totally dislocated. So you need open reduction plus minus bone graft with whatever luminary fixation with KYs or plate. If you are putting bone graft, then you can go for a plate. Right side relatively subtalar joint, you have to just stabilize the subtalar joint using wires and get out the wires.
Right side, we have conservatively we have done it, sir.
So right side is intraarticular or extraarticular? Calcaneal fracture, right side.
Intraarticular, sir. It looks like intraarticular. Some sort of combination is there, sir. Here.
Intraarticular or extraarticular?
Intraarticular, sir. Here, if you look at left side, also intraarticular only, sir.
So is there any difference? No difference.
Left side, it is more comminuted. Calcaneum is more comminuted, sir. Calcaneum left side.
And cup?
Talus okatum, sir. Talar neck fracture.
Did you, in the right side, did you think of looking for any angles?
Angle.
Bowlers, Gizeners.
Did you think of the moment you have seen the X-ray? Did you think of regarding the 2 angles?
Bowlers and Gizeners.
Did you think of those?
I did not.
You didn't think of.
It is necessary, sir.
Radiographer కూడా చెప్తాడు. Calcaneal fracture. He is the first one to report to the patients, irrespective of whether they ask or not. What is happening to the bowler's angle here? What is the other angle?
Gizeners angle.
What is happening to who?
Bowlers will increase, sir. Gizeners will decrease, sir.
ఇక్కడ సంగతి చెప్పలేదు.
Pointer, sir. You have to get podium presenter, you have to have the pointers.
They get
సారంగా ఏం విమర్శగా నువ్వేం దొరా పాయింటర్స్ ఖచ్చితంగా దేవులు పెట్టిన వాళ్ళు పెన్నులు పెట్టినట్టు
everybody but carry a pointer.
మీరు presentation అప్పుడు you know you are presenting. You have to come to the
Show what is bowler's angle, what is distance angle.
We have to take a line like this, sir, and one more line like this.
What is the other name for that anatomical description? The bowler's angle. What is normal, what is abnormal?
I have to revise once, sir. Sorry. Revise once.
Revise that. Have you read at least once? If you have read once, that is called revision.
Yes.
That is called tuber joint angle. Normally it is about 40.
Yes.
Anything less than 30 is collapse. That is accounted in isolated tuberosity fractures. Here there is a subtalar joint extension. Fracture is extending. Anterior end of the calcaneum is fractured. And show the distance angle.
I don't know, sir.
Can you? Anybody? There are two joints, anterior subtalar and posterior subtalar. Draw a line from the posterior most part of the posterior subtalar to the non-articular area in the calcaneum, and another line from ear to ear. That is concave. When the bone is collapsed, it becomes straight. Here it is almost straight. That is angle of descent. Okay.
This angle is an obtuse angle more than 90 degrees. Here it is. Bowler's angle is 35 to 40.
Okay, you have to restore. Otherwise, they will develop subtalar arthritis at a later date.
So ultimate goals of management of calcaneum is maintaining of
Subtalar.
What is done for the right?
congruity and the breadth of the calcaneum. Everything will be taken away.
We have put only one screw for.
Fracture is an absolute fixation.
Yes, sir. We have done only. We have fixed the talus bone with only one Herbert screw, sir. What we plan to do is after 12 weeks, maybe we will put a tibio calcanean nail so that the patient is free of pain.
Why did you plan so?
She will definitely have subtalar arthritis, sir. No matter what.
Are you predicting the prognosis right now, or you are trying to?
I'm predicting the prognosis, sir.
See, were the fracture fragments very sticky? Was it malunited? What's the reason that you want to do a fusion straight away?
Not straight after 12 weeks, sir.
So your plan is that only, no?
Yes, sir.
So why not now? Why not you get the joint reduction? Were the fracture sticky?
Actually, what we thought was since the calcaneum is very comminuted, if we open it, there may be. We may.
Back of bones.
Yes, sir.
Back of bones calcaneum. Usually people don't operate. Whatever you do, it is going to be, the result will be very poor.
Yes, sir.
So treat them conservatively. After some time, when they develop subtalar arthritis, fuse it.
Yes.
Okay, subtalar, and it is not only the talus that should be fused. It should be a triple arthrosis.
Triple
Because
arthro.
talus involves the calcaneoprovide joint also. Calcaneoprovide alone will not do. You have to do also
Talnavicular.
talocalcane, sorry, talonavicular.
Yes, sir.
There is a single complex. Okay.
Sir.
Then you can reduce the cavers. You can get the cavers, you can put it in.
Yes.
Even if you have to put a tibio-talocalcaneal nail, you have to put screws to the calcaneum.
Yes.
Those are two cross screws perpendicular to each other. Then you should have some bone, right? To
Yes,
put the screws. With no bone stock, what will you do?
Yes, sir. Sir, the Hawkins grade 4, sir.
You are asking or telling?
I'm asking, sir. I have doubt that. Yes, sir.
operate it and get the shape and reduce the width and gain the height of the calcaneum, so that even though the subtle arteries may develop, so get the shape and height of the bone, then you can orthotics in a good position. If the width of the heel increases and height decreases, there will be pain even though you feel. So get the height and reduce the width of the calcaneum. So forget about the orthosis.
Otherwise, they will develop a flat look. Reasonable alignment.
Because it is a closed fracture, that way you are very lucky. So you can try manipulation, you can try, and you know how it is under anesthesia.
Yes.
You can try the K-verse and all those. Multiple K-verses.
The
Why one Hubbard screw?
the head was very small, sir. So passing of another headbutt screw was not possible during intra-op period.
Already done a lateral approach, right? Almost like an extensor lateral.
We have done anteromedial approach, sir. Only anteromedial we have done. No lateral approach.
Two screws, otherwise each one more cable. And moreover, you have to get the compression.
Yes.
Some people, you are passing the effort from anterior to posterior, posterior to anterior.
Anterior to posterior in a retrograde fashion, sir.
Two approaches there. Some of the time in talar fracture, 1 month old and all those things, you cannot able to achieve the anatomical reduction. In those cases, you have to osteotomize the
Medial malleolus.
You open it and go, you can come back.
Yes, sir.
Yes, sir.
Next.
22-year-old female with synovitis of the left knee, tubercular with joint effusion, sir.
How did you say it is tubercular?
Sir, she had a history of same tubercular synovitis of the right knee 7 years back. She was operated in Usmania, sir, 7 years back. Now left side also she is complaining, sir.
Right side she became normal?
Yes, sir.
It was only synovitis at that time? Or operating?
They have operated, sir, right side also.
No. Right side, was it operating or only synovial stage it was treated?
Is it operating stage or synovial stage? Jubilee.
Right knee is clinically normal?
Normal, sir, right.
So right knee is operated. How many years back operated?
7 years back, sir.
So that is also confirmed at tuberculosis. No. She has completed the ATT treatment.
She is on ATT, sir, now.
Now 7 years back operated.
Again,
7 years back she is operated for right knee dyspnea. She has taken the complete course of anti-tubercular treatment.
she has started 7 months ago, sir.
First right knee dyspnea treat చేశారు.
అవును, sir.
They will not be able to remember.
కనీసం చెప్పాలి కదా.
Invariably they don't complete the course.
Irregular treatment.
Now where is the plain X-ray? Very comfortable. You have to focus on the knee.
Yes.
It is taken for the thigh including the knee. It is the problem is in the knee. You have to take a separate knee X-ray. It's not there.
Not there.
Not done. That is what is required. You see, you can't, the film is not centered, the tube is not centered over the knee joint.
Yes.
It doesn't give a true representative pathology of the knee. Should have taken the knee X-ray. I can't read anything from this X-ray. Okay.
Is there triple deformity? No triple deformity. What is triple deformity in case of tuberculosis of knee joint?
Don't know, sir.
Yes, sir. Next.
Already it's already clarified. We have got so much of
Posterior subluxation, posterior subluxation, external rotation. Why posterior subluxation? Why flexion? Why external rotation? Anne cheppali. Triple deformity of knee joint in tuberculosis of knee joint. Yes.
So we have done partial synectomy, sir. Intra findings would be the quadriceps muscle was atrophied, sir. Half of fat part was also atrophied. The antrum.
What was the plan?
Partial synovectomy, sir. Yes, sir.
She has already developed arthritis.
Yes, sir.
Will synovectomy do better?
In the future, if they again have problem, sir, we will fuse the knee joint, sir.
Is it not the stage for fusion?
Why fusion?
No, what is the advantage of
22-year-old.
Yes, sir.
Totally different situation.
Already arthritic, sir.
There is one more option for orthoplasty.
Sir, already TB infected knee, very, very high risk of again infection, sir. If you do TKR even.
They do operate even on TB.
Any infection-free period of more than 18 months, you can do for a THR or a TKR. If you read Tully's book, after the new updates also, they tell 2 year, 18 months to 2 year disease-free period after they have completed 8 weeks.
So what is the advantage of partial salvage? Is for diagnostic purpose or therapeutic purpose?
Both, sir.
Both. So what is the diagnostic purpose?
We have sent it for histopathological examination, sir.
Or operating you got any caseous material?
Yes, sir.
See, already
Yeah. Articular cartilage soft tissue?
Condyle
Yeah.
already completely denuded of the
Yes.
cartilage. The bone is exposed of condyle bone.
Yes, yes, yes.
Here.
What about the muscle status? Weak.
Very, very atrophied, sir.
Purpose of
Weak.
spinectomy is to get the ATT penetrated better to the site of pathology, so that the ATT will be more effectively working. That is one advantage. The bulk of the synovium can be removed and then mobilize the joint so that they will get some useful range of movements. What is the range of movements?
90 degrees it is.
90.
Flexion is 90 degrees.
And of course it also serves as a biopsy.
Biopsy purpose.
Cruciates are necrosed or intact.
ACL anteromedial bundle is atrophied, sir. Posterolateral bundle is intact, sir. Whereas menisci also are degenerated, sir.
Collaterals are intact.
Collaterals are intact, sir.
Very good, sir.
This 17-year-old male with compound middle third shaft fracture of left femur, sir. We have done close reduction internal fixation with interlocking nail, sir.
So why you have taken long nail here?
Shaft fracture, sir.
Okay, so grade 1,
Grade 2, sir. 2 years, sir.
40 years old female with 6 weeks old cause dislocation of left elbow, sir.
Is the image side focus, anatomically focused or anatomical variant? Always read
Yes. Good morning, sir. Good morning, sir.
Okay, go on. You put it upside down, is it?
Yes, sir.
But you should tell them routinely. If they are putting that means it's your fault. You're not teaching them properly. Okay, go on.
We have done open reduction interfixation with K-wire, sir.
Why K-wire again? Go back. It was not stable?
Yes, sir, not stable.
Who did this?
Serum, sir.
Should not put K-wires through the joint. Okay, next.
Otherwise they will get dislocated, sir. They get dislocated and post-operatively will repent. Of course, theoretically speaking should not be.
If they are dislocating means there is a ligament problem. We should repair the ligament. Primary repair of the ligament. Okay, go on, next.
This is a 57-year-old female with intertrochanteric fracture of left femur, sir. We have done a close reduction internal fixation with long PFN, sir.
Okay, go on, next.
Thank you, sir.
39-year male with grade 1 middle third, distal third, both bone fracture of left legs. We did close reduction with ILN for left tibia.
No clinical pictures. There should be 3 clinical pictures, pre-op and post-op. Oh, these are pre-op.
Yes.
That's a puncture one?
Yes.
Good.
Good morning, sir. This is a 47-year-old male with a closed distal and both bone fracture of left ankle.
Is it both bones or something else?
Both bones, sir. There's a tibial fracture plus fibular fractures with the intra-articular extension also. Rudy Algover type 3.
It is intra-articular fracture.
Yes.
Yeah. Is it pylon fracture?
Yes, sir.
Yes or no?
Yes, sir.
Yeah, go on.
We have done plating for fibula and K-wire fixation for tibias.
Any posterior malleolus?
No, sir.
Okay. Was it stable?
Yes, sir.
Forward.
This one, sir.
This is the one. Okay, looks okay, but very comminuted. Screws were not possible here?
No, sir.
Okay, next.
This is a 8-year-old male with 4-week-old closed proximal third fracture of left ulna with a radial head dislocation, sir.
Yeah. So what was done?
These are the we have done open reduction internal fixation with plating for ulna and radiocapitellar joint fixation with K-wires.
So it was unstable.
Unstable. We could achieve close reduction of the radial head, and it is popping up. Both in AP and lateral.
Looks good.
The last week's journal presentation she made.
Yeah.
Chronic multi.
Yes, yeah.
That article has really helped us.
So, see, that makes a big difference. If you present something, if it's going to affect your practice, you're going to change your practice because of something from journal, that's useful.
Thank you.
Yeah.
With that article, what I have learnt is, normally our tendency is to make the ulna straight and struggle with the reduction of the radial head. In that presentation, they have drawn some lines and angles, and they have purposefully angulated the ulna so that the radial head reduction will be feasible on the table. Otherwise, if you try to maintain the normal alignment of the ulna, you will never be able to reduce the radial head. That is why you have bent the plate, and then only it came back into the alignment,
So
radial
radial
head.
head reduction is important.
Yes. The fracture angulation.
Yes, sir.
Okay.
Very good. Excellent.
Thank you, sir.
Next.
So your topic has helped us.
Thank you, sir.
Yeah, very good. Good selection of the topic. 2 cases, sir.
Yeah. All right. Okay.
Good morning, sir. There is one case for discussion, sir. 8-year-old girl brought with complaints of pain on walking for long distance. Mother noticed limp since she started walking at the age of 8 months. Her gait, sir.
So was it painful?
Painless limbs.
Yeah. So what type of gait is that?
Tender lumbar gait, sir.
Is it? Which is normal knee, which is abnormal knee?
Right
abnormal
is
hip, huh?
Right is abnormal limbs.
Ah. So what's happening when she's standing on the right?
Sir, lurching.
Look at now. Look at now. Not lifting up.
Yes. Short
No,
limbs.
it's basically stable short limb.
Yes, sir.
Okay.
Between short limb gait and the Trendelenburg gait is present. The shoulder dips and the knee gets flexed when the right lower limb is straight.
To balance.
In the short limb gait. That is the difference between short limb and the Trendelenburg gait. In Trendelenburg gait, there will not be much limb length discrepancy.
And there is no pelvic tilt when you are. Go on. No problem. So what do you think? Clinical diagnosis.
Just tell the positive clinching point for clinical diagnosis. The range of movements is one.
On examination, there is no exaggerated lump.
You summarize. Put your PowerPoint. Examination is okay. Go on. Examination.
On examination, there is no exaggerated lumbar lordosis, painless limb, and right ASIS at the lower level. There is apparent shortening present, Galeazzi sign positive, and cordyceps wasting with present.
So no exaggerated lordosis means? What does it indicate?
No.
What does it indicate?
When she is walking.
No. What you're trying to say out of this finding? It's a
Backbenchers, not looking at sir. Sorry,
Flex.
one way I asked the question.
They're trying to prompt him.
You should have taken a clinical picture.
Yeah. Okay. Quickly, what is the importance of? If it is exaggerated, what do you think? When it gets exaggerated? It exaggerates because of spinal deformity, knee deformity, or hip deformity?
Hip deformity.
What kind of deformity? Hip?
Flexion.
Oh, yeah, that's what. So he concealed flexion deformity. Go on.
Deformities and movement, there is no fixed deformities present. On movements, flexion, there is a full range of flexion. Abduction, right there is 40 degrees and left 70 degrees. And adduction, right 20 degrees, left 30 degrees. Rotations in extension, internal rotation is 0, external rotation is 70. In flexion, internal rotation is 20 and external rotation is 50. Measurements, there is apparent shortening of 2 centimeters and true shortening of 1 centimeters. Telescopic test is positive and Trendelenburg test is positive. This is a clinical pics of adduction and abduction. This is a present.
You already suspense, you opened the suspense, yeah. You already. So what are the possibilities? Diagnosis. What could be the, take your mask off. What could be the possible differential diagnosis?
DDH or septica? There is no history of fever or there is no history. No history suggested. There is no
So it's a classical presentation of a DDH. Or could it be Perthes? Could it be Perthes?
Yes, sir.
Is that 8 months, since 8 months,
Since
it's common?
At the age of 8, when she started walking, from the time she is having the same
Limp.
gait, limp, sir, limp gait. So Perthes, it is development when she,
Yes. So it's unlikely. So your most of the common diagnosis would be DDH, and it's not painful, no history of infection.
No history of fever and no history of
So,
infections.
Okay. But possibility, yes. Okay. What do you want to do next?
So
Okay. You already shown the X-ray.
This is a present X-ray, sir. X-ray shows dysplastic acetabulum and capital femoral epiphysis is a hypoplastic, and there is a shallow acetabulum.
You think acetabulum is dysplastic?
True, just
Not dysplastic at all. Did you draw the lines?
Lines.
Not, I think acetabulum looks quite normal to me.
But when you compare with the other side, it's very shallow. Sir.
Probably because it's not articulating, that's why it's not contoured. But I think it's originally, probably it.
I asked you to put the clinical diagnosis as DDH.
Okay. So these are the dysplastic, probably not very hypoplastic. What else it could be? Taking from, was it a normal delivery?
Yes, sir.
It was normal delivery.
Normal delivery and milestones are normal.
Good.
First trial, sir. Only thing is first trial.
Was it a hospital delivery or home delivery?
Hospital delivery also.
So could it be post-traumatic?
In first deliveries, it may be.
But this doesn't look like a classical DDH. It doesn't look like classical DDH.
Yes, sir. Shallow.
Yeah. There is no remodeling, but probably, hopefully, that is that is capital femoral epiphysis. Yeah. Like a mushroom. Okay. So what's your diagnosis?
DDH.
Very unlikely DDH. DDH. Yeah. Right. Okay. Quite possible. Because acetabulum, if it's non-articulating acetabulum is like that, means it's quite need to get remodeled. Enough pressure is not there. By birth is not. So DDH is not. DDH is completely shallow. It's really shallow. See, completely straight, and there is no. Yeah. And the cartilage is now, everything is normal there. Yeah. Could it be traumatic?
There is no history of
no history. No. Infancy. Yeah. More birth trauma. That's unlikely.
There is no prenatal, perinatal, everything is normal, sir.
But this also doesn't look like classical infection. There is, see, femur up to there is quite normal, and that also not shape. 8 years back, yes. Probably it's remodeling and and it's articulating there.
Some small remnant of the head might have been left.
Sure.
Region,
yeah, quite possible.
We have X-ray at the age of 2 years also, sir. This is X-ray at the age of 2 years. The small remnant.
Oh, that's very important. They just keep this one. So there is a delayed. Delayed. So she was seen somebody at that stage. What was the diagnosis made at the age of 2 years?
At the age of 2 years also they have made DDH, sir. She went to Bird's Hospital. Bird. Tirupati.
It's quite normal.
Here it's normal.
You should measure the angles of the acetabulum. That it should be normal. Trichoradial cartilage is normal. Slope is almost normal. I think there is problem with the capital femoral epiphysis, and there is no delayed formation. Okay, interesting. Keep this X-ray as well.
Okay.
Can rickets produce this type of presentation?
No.
No, it doesn't.
No.
Okay.
If it is DDH,
okay. Procedures, right?
Procedures.
So irrespective of the pathology now, the treatment is not going to alter. Okay?
Absolutely.
Essential point.
So first we'll take CT and we'll
We will do a bit more. Send me a copy of these ones.
Okay,
I'll
sir.
send it to the pediatric home, London pediatric home. Let them find out what.
Okay. Okay, sir. Thank you, sir.
Excellent. I think. No, I think this one needs proximal femoral osteotomy. Acetabulum is normal. Acetabulum is normal. Okay, general club here. General club. One case, okay, go on. Now presentation. Go on, go on. Quickly. No. Problem, right.
So this is a case of lytic lesion in proximal femur in a 12-year-old boy. 12-year-old boy with complaint of right hip pain since 1.5 years, which is slowly progressive type. There's no history of trauma, no history of femur, no other joint pains, no rest pain, and pain is only present in terminal range of movements in all directions. There's no fixed deformities.
Yeah, come out, it will play. Yeah. So you speak when you describe what is a gait. Is it normal gait?
No, sir. Yes, pain while walking.
But easy complaining of pain, he's happy, he seems to be smiling. Huh? That looks quite normal to me. Slow gait, stable gait. Okay. You label the presentations, not labeling. That's why it's difficult to find out the PPTs.
The clinical pics, abduction, adduction, internal and external rotations.
Okay.
So this is X-ray done last month, sir.
So what do you think? We'll ask, I think, finalist students are here. Vivek. Where is Vivek?
OT.
Who else is there? Yeah, yourself. What do you think? This is important, your examination case. What is there? Describe. Should not say lytic. Lytic means it you are committed for malignancy or infection. Okay. Lucency, you can say. Yeah. Where?
Cystic.
Cystic. Okay. Proximal femur. Okay. And anything in the physis? Yeah. Well defined, ill defined.
Zone of transition.
This is well defined or ill defined? Well defined. We also always. And what happens to the shape of the proximal femur and neck? Coxa magna? Coxa magna means large head. They look same. Metaphyseal widening. Yeah. Widening of the metaphysis. Yeah.
Matrix of the tumor. That is also equally important. Looks like the ground glass appearance of the whole femur. Widening of the metaphysis as well as the subtrochanteric area, the thinning of the cortex, wide medullary canal. You can compare the normal bone.
Other side, yeah.
Bone is wider.
Mainly affecting this part.
And also the entire shaft cell.
What? Yeah.
Cortex is very much thinned out.
Thin, yes.
Uniformly thinned out.
Bottom, I think this looks okay. Right one, yeah.
And abnormal anterior bowing.
Yes.
With
So what do you think? Any possibility? Anybody knows? Any senior residents here? Pradeep? Is he here? No. Yes, okay. What do you think? Interesting, this is also. You are very fortunate to have combination of what is a government medical college and a corporate setup. You get both categories of cases. Both extremes. Huh?
Both on same day.
Same day, yes.
Yes.
Extreme.
Both hip problems.
Hmm.
One girl, one boy.
Yes.
Anybody? Lakshmikant? I am not asking your opinion. Yeah, fibrous dysplasia, could be fibrous dysplasia. 8 years old.
12-year-old.
12-year-old, okay. So what do you think?
It can be fibrous dysplasia, sir.
Okay.
The next.
What are the lesions which will affect metaphysis and epiphysis?
Epiphyseal chondroblastoma can be there.
But that should not affect metaphysis.
Yes.
Affecting both means it's a generalized bone disease.
Yes.
So fibrous dysplasia,
can
one
be
of the.
better option.
Can it be any tumor? Can it be, oh yeah, somebody saying giant cell tumor. Could it be giant cell tumor?
Epiphyseal, it is young.
Will it be it cannot be single joint cell tumor, it should be multiple.
Yes.
Very unlikely.
Yes.
Yeah.
And where before
Skeletal maturity.
But GCT doesn't happen both metaphysis and epiphysis.
Epiphysis, both.
growth plate is disturbed or normal?
Go back, previous X-ray, you see growth plate better or no? Okay, go on, next one.
So this I've tried to summarize lesions coming from epiphysis, metaphysis and diaphysis according to the age and the specific radiographic.
We can't read. Can you read? We can't see.
Yeah.
Tell. Okay.
The epiphysis chondroblastoma, infection,
yeah, good.
Langerhans histiocytosis and unicameral bone cyst. In 5 to 15 and the maximum 25 years.
Okay.
The metaphysis, ABC, osteomyelitis, osteosarcoma, non-ossifying fibroma, and fibrous dysplasia.
Okay.
Diaphysis, malignant Ewing sarcoma, LCH, osteomyelitis, fibrous dysplasia, and leukemia or lymphoma.
Yeah.
Can fibrous dysplasia can affect the epiphysis, metaphysis, diaphysis?
Yes.
Yes, it can affect all.
These are the kernel
Oh,
MRI.
okay.
Put the representative. Zoom this in Nadena.
This
Yes.
one?
Yes.
So what do you see? Any soft tissue involvement?
No, sir.
No soft tissue. So that rules out malignant tumor.
Malignancy.
And infection can also be ruled out.
There is no elevated.
There is no reparative process going on.
Yes. No periostitis.
But it cannot be ruled out totally. Of course, one more important point, any bone resorption, tuberculosis also should
Yeah,
be
TB always.
last possibility.
3 T's are very important in all. 3 T's are very important in orthopedics. Trauma, tuberculosis, and tumors. All is a differential diagnosis for any long case, unless otherwise proved.
Okay.
So this axial
this is-
sections. There's no soft tissue involvement, sir.
Okay.
Growth plate appears
So,
normal here.
Yes.
so MRI helped you or added any value for diagnosis?
Yes, sir.
So ruled out malignancy.
Yes, sir. No soft tissue involvement is one thing. But MRI showed other multiple focal lesions in both iliac bones, bilateral ischium, right acetabulum, right pubic rami, right femur head, neck of right femur, shaft and distal epiphysis of both femurs.
Okay. So they've suggested polyostotic fibrous dysplasia, LCH. What is LCH?
Langerhans cell histiocytosis.
Langerhans, okay. That's a possibility. Oh. But that's epiphysis or metaphysis? Anybody? Langerhans cell. Epiphysis. Differential diagnosis for epiphyseal. Diaphyseal, yeah.
Langerhans giant cells are there, Langerhans cells are there. Both are different. Can you get it in tuberculosis?
Okay. Right, okay, this one.
So we did investigation, serum alkaline phosphatase is
So what
elevated.
did he say? Go on.
So we did investigations. Phosphorus and serum calcium are normal. Alkaline phosphatase is increased, and increase in PTH is
What is the
present.
normal value? Alkaline.
Near 100, so less than 100.
But
88.
you put this one for normal, you didn't put the. Huh? Okay. Raised alkaline phosphorus, very
Raised,
high.
yes, sir.
Okay.
And elevated PTH.
PTH is also.
CRP and CBP are normal.
Normal.
Yes, sir, is slightly elevated.
Okay. So what do you think? Maya, what's the differential diagnosis now?
Fibrous dysplasia, polyostotic one, because it is involving the pelvis as also.
That alkaline phosphate is increased in
Light.
fibrous. Is it increased in fibrous dysplasia?
No. The lytic lesions, it is increased. Sir. No.
Not all.
Lytic lesion, acid phosphorus. Elastic lesion, alkaline phosphorus. Both are different.
So could it be related to PTH? Hyperparathyroidism, because levels are high. Should
Not.
see.
We need to do X-ray of the both hands.
Yes.
Could be.
It may add to our diagnosis.
Secondary hyperparathyroidism.
What is Brown's tumor? Brown's tumor.
Parathyroid adenoma. Parathyroid adenoma.
So anything is done?
Yes, only test.
I think biopsy, true cut biopsy. True cut biopsy, because difficult to get any material, but if you go into the cavity and metaphyseal region, junction of a normal abnormal bone under the C-arm, I think we should do biopsy before. That will also tell us whether it's a parathyroid tumor or any other. Yeah, skeletons are there. Ultrasound of the neck.
Yes.
Yeah. Sure.
Yes.
Okay, next one. X-rays you are presenting?
No, general.
General. Interesting, very interesting. If you see one case like this every week, I think you will become excellent orthopedic surgeon.
Good morning, sir. This is a journal club about review literature of systemic review and meta-analysis of clinical outcomes following meniscal repair in patients 40 years and older. Is a journal club from UK, sir. Published in 2024 in the Orthopedic Journal of Sports Medicine by Chadwick, Christopher Sanders and Jed Good. This is the purpose to establish the clinical performance of meniscal repair in older patients and compare it with the performance in younger patients. The introduction.
Read the summary, abstract.
Background, sir. Meniscal repair has been
Background, purpose of the study.
to establish the clinical performance of meniscal repair in older patients and compare it with the performance in younger patients.
Okay.
The systemic review.
Read all the, you get summary from here itself.
This is a systemic review. Systemic literature review was performed in September.
Not systemic, it's a systematic review.
Systematic literature review was performed in September 2021 using Embase and PubMed to identify published English language studies that reported on a meniscal repair in more than 5 patients aged more than 40 years. Outcomes of interest were success and failure rate, revision meniscal procedure rate, and patient reported outcomes. Meta-analysis were used to synthesize outcomes across all studies in older patients, and meta-analysis were used to compare outcomes between older and younger patients.
So anybody done more than 5 patients, they have included. Okay, go on.
Results, 14 studies were identified. Meniscal repair in older patients were determined to have a failure rate of 12% and a revision meniscal procedure rate of 9.8%. The post-operative Liscombe score was 86.7, and no statistical significant differences were observed between older and younger patients in failure rate and revision meniscal procedure rate or Liscombe scores. Conclusion,
Meniscal repair is selected patients aged more than 40 years, resulted in good success rates and patient reported outcome measures which appear similar to those reported for patients aged less than 40 years. Therefore, meniscal repairs can be performed in at least a specific portion of older patients, and age per se should not be the sole determining factor in whether to perform a meniscal repair.
Okay. Yeah, go on. Yeah, really. Yeah, are you?
Sir,
showing
basic
me?
anatomy, sir. Between lateral meniscus and medial meniscus. Medial meniscus is larger in diameter, C-shaped, thinner in periphery, thinner body and less mobile, not attached to ACL and PCL. Lateral meniscus smaller in diameter, circular, thicker in periphery, wider body and more mobile and attached to ACL and PCL.
So which one is prone for more tears?
Medial meniscus.
Why?
So no attachment to ACL and PCL, and lateral meniscus is attached to popliteus muscle. And there is a two tendons.
Less mobile one will be torn more or more mobile one?
Another support is there for lateral meniscus.
Question is, which is more prone, less mobile or more mobile?
Less mobile.
Less mobile because fixed. Like radial nerve in the radial groove, less mobile. Doesn't escape. Okay.
This is anatomy and this is cross-sectional view. The vascular supply. Here it is a tear. There is no less vascular supply.
So read about it. Red
based
zone.
On, based on the classification,
Yeah.
There is a 3 zones: red zone, red-white zone, and white zone.
Okay.
Where the vascular supply is more in red zone, and decreased towards a white WW zone.
Okay.
So based on the type of tear, classification done, sir. Longitudinal, horizontal, oblique, and radial, and flap tears, bucket handle type, and oblique tears. The longitudinal tear. Longitudinal tear in cross section.
So did they say in the what type of tears were included in the study?
Yes, sir. All tears except root tears, sir.
All tears except root tears.
Root tears.
Right. Okay.
The radial tear, and oblique tear, flap tear.
These all were repaired.
Yes, sir. Two options for meniscectomy and meniscal repair. Meniscectomy, partial meniscectomy, subtotal and total.
Meniscectomy only. C is silent. Meniscectomy.
And meniscal repair. That 4 types are inside out, all inside, outside in, and transtibial pull out. Meniscal tears are one of the most.
So this one probably they have done everything because it's a multi-center. You only review, literature review.
Yes. Meniscal tears are one of the most common soft tissue injuries of the knee. The total or partial meniscectomy and meniscal repair. Compared with meniscectomy, meniscal repair has been associated with lower risk of degenerative cartilage changes, lower risk of total knee arthroplasty, and better outcome. So there is a article, sir. Meniscectomy is associated with higher rate of osteoarthritis compared to the meniscal repair. Meniscal repair appears to be more commonly accepted as the standard for care in younger patients. But meniscal repair in older patient is less likely to be successful due to reduced vascularity across the meniscus and increased likelihood of degenerative tears. This article shows that the overall vascular density decreased with increasing age. No vessel formation were detected in red, white, and white zone after adolescence. So thinking that less results are due to more degenerative changes in knee, there is a contraindication for meniscal repair in older. But this systematic review reported a pooled meniscal repair failure rate of 10% studies in patients with aged 40 years, stating that rate is similar to the rates reported for younger patients, and another systemic review reported that older age did not increase failure rates. These previous systematic reviews were limited by small sample size, inconsistent definition of failure across studies, and lack of meta-analytic techniques. This study aimed to establish the failure rate and patient outcomes after meniscal repair in older patients and how these outcomes differ from those in younger by prior systemic reviews of each study and cross studies for resurgery.
Okay.
So methods, there is a systematic review upon 2 earlier systematic reviews.
Somebody discussing behind as well?
And an updated literature in PubMed and Embase up to 2021. Inclusion criteria: patient aged more than 40, undergo meniscal repair with or without knee procedures. Studies had to report outcomes like success or failure, individual study, revision rates, and patient outcomes. Both comparative and non-comparative original research studies were included, and screening was done via titles, abstracts, and full text review. The study characteristics: two reviews and updated literature both are included. From two reviews they included 8, and from updated literature research they included 6 total. They included 14 studies. Data: the patient characteristics include age, tear type, location, size, and chronicity. And surgical factors included repair technique, device, and other concomitant procedures. Outcomes assessed were success or failure rates, revision surgeries, and related outcomes with central tendency and variability. Meta-analysis was performed to pool meniscal repair outcomes in older patients across studies, and meta-analysis was performed to compare meniscal repairs outcomes between older and younger patients. Forest plots were displayed, individual studies and heterogeneity, and sensitivity and publication bias analysis was performed. These are the results for included only studies. 14 studies are included. In these retrospective case series have taken, retrospective cohort studies, and prospective case series are.
So majority retrospective
cohort studies. They included age group and number of patients. These are the failure rates, sir. Where the patients receiving meniscal repair and patients with meniscal repair failures. They included all the type, medial and lateral meniscus, included horizontal tears, complex horizontal and radial tears, tears which are less than 2 and more than 2 centimeters, acute and chronic, and based on the location, and concomitant ACL reconstruction, and the technique. Higher failures.
Complex and radial tears is higher
failure.
Chronic tears higher rate. Isolated repair with an intact ACL also is
higher failure. Meniscal repair failure defined includes clinical failure determined through physical assessment, failed meniscus healing determined through MRI and second look arthroscopy, the need for subsequent surgery, and poor patient outcomes post-operatively. A combination of meniscus healing and subsequent surgery, combination of clinical symptoms and meniscal healing, and combination of patient outcomes and subsequent surgery. MRI or second look arthroscopy leading to the definition of failed meniscus healing was most commonly performed in systematic patients. These are the results. 58 meniscal repair failures were reported for older patients. This is the proportional meta-analysis. About 12% failure rates, and meta-analysis for comparative studies between younger and older children, the lower risk of meniscal repair failure in older than younger patients. This is the meniscal failure rate as defined by individual studies. And these are the meniscal failure rate by meniscus reoperation. 9 studies provided information to consider failure as a revision meniscal repair or meniscectomy in meta-analysis. Meta-analysis identified 9.8% in older patients, and 7 comparative studies comparing between the older and younger patients shows less likely to experience failure. Result: studies reporting on meniscal repair failure as defined by each individual study tended to demonstrate relatively high failure rates in small case series and low failure rates in larger case series. Meta-analysis performed on post-operative Lislam score identified no statistical significance between older and younger. No statistical significant differences were observed between older and younger patients in failure rate in revision meniscal procedure and Lislam scores. Discussion. Meniscal repair failures in patients more than 40 years is 12% in overall failure and 9.8% in requiring reoperation. No statistical difference in failure versus patient less than 40 years. Supports repair in older patients with proper selection of patients. comparable and lower failure than general population. All tears are 12 to 23% and bucket handle type 15 to 29%, horizontal cleavage 12 to 26% and radial is 8%. Lower failure rates seen in lateral meniscal tears, smaller acute tears, red vascular zone, vertical longitudinal tears, and concomitant ACL reconstruction, and modern all-inside techniques. Possible reasons for low failure rate are low activity levels in older patients and patient selection by surgeons. Meniscal preservation and clinical impact. Shift from meniscectomy to meniscal preservation due to reduced osteoarthritis risk and low likelihood of total knee arthroplasty. Benefits seen even in older patients with early degeneration. Post-op osteoarthritis grading unchanged in some studies. Encourages repair when patient and tear factors are favorable. Limitations of existing evidence, variability of definition of failure, and inconsistent data reporting on tear characteristics, that is root tears, and patient activity levels after more than 40 years. And selection bias, repairable tears chosen in older adults, and highly reliance on retrospective studies and between study comparisons. Conclusion: meniscal repair can be performed successfully with a low failure rate and good patient outcomes in older patients. It is unclear if these outcomes are equivalent to those in younger patients, as selection bias in surgeon decision making may confound observations. It is apparent that successful meniscal repair procedures can be performed in this age group through diligent patient selection. Therefore, age per se should not be a primary or sole factor in deciding whether to perform meniscal repair. So the reason. Acute tears.
All are acute.
All are acute.
But you said some failure rate depend upon the duration of the tear as well.
Yes.
Retrospective study, so probably. Okay.
Recent advances in meniscal. Enhancement of meniscal healing, arthroscopic repair of torn meniscus using fibrin clot, fibrin glue, and meniscal replacement, allograft meniscus, allograft facial material, synthetic meniscus, and newer techniques by hydrogels, hybrid hydrogel, and growth factors and cell-based therapies.
Yeah, very good. I think it's see, the main message is you should not excise the meniscus. Try to save the meniscus. There was a campaign about a couple of years ago, save the meniscus. Previously, all the meniscus were treated by meniscectomy. But nowadays, I think a majority treated by meniscal repair, unless it's not repairable. The disadvantage of a retrospective study is they have selectively chosen. That means those who are high chance of healing, they have repaired, remaining not repaired.
Yes.
And they have all inside devices which are very popular. So now obviously they promote to older population also. Those things have to be given to the audience.
So it's a biased one, isn't it? There is no evidence to say that all inside is superior to other methods because of their device they probably promoted. That also important, as Ravi said. If it is sponsored by a company, there is a lot of bias.
Ultimately, when you talk about the functional result, your criteria is only age or type or acuity, or there is something else. High demanding people.
All should be taken.
High demanding people,
High demand.
people in over 40 years is a high demanding sports. Sports injuries is a totally different entity compared to the trauma.
Yeah, I think all factors.
Yeah, all should take. Well, age,
Okay.
40,
Good presentation. The message is you should try to repair or save the meniscus. Already 11 o'clock. Okay, thank you.
Wait. The two cases, hip cases, those we have prepared already. You present it in CCY's meeting on 6th, I think. Is it on 6th? Where are you? You present it there. Okay, both of you.
Yeah, I think so.
Others also can attend.
This was Sunday, I think second year and final year can attend.
Before presenting, show it to me.